Natural medicines to manage diabetes. I have no actual or potential conflicts related to this program. Some surveys have shown that more than 50% of people with diabetes use some type of supplement. Now, these can be for many different reasons, but in this program, we're going to focus on those that are used for managing glucose. So we're going to review the scientific data to support or refute the use of many of these agents, such as cinnamon and chromium. We'll discuss the effectiveness evidence for the various supplements. As we talk about each supplement, I'll identify the factors such as adverse effects or drug interactions, contraindications, etc., that may limit the use of the discussed agents. Throughout the program, we're going to apply the material to some patient cases. Thus, hopefully, you will be able to use this information in your daily practice. Before we delve into the various supplements, I did just want to make sure we were all on the same page when we talk about glucose and hemoglobin A1C goals for patients with diabetes, because we need to know this information when recommending supplements and when assessing the efficacy of how much do they change glucose and A1C. For the majority of patients with type 2 diabetes, and that's really who we're focusing on today, their A1C goal is to get to less than 7%. Now, that obviously can be modified based on other things that are going on with the patient. They may need a tighter goal, they may need a looser goal. Pre-prandial or fasting glucose values should be 70 to 130 milligrams per deciliter, and looking at peak postprandial glucoses less than 180 milligrams, and postprandial being within 1 to 2 hours after starting a meal. Typically, you will do it at about 2 hours after the meal. Because A1C is a difficult concept for many patients, the American Diabetes Association does recommend now that we translate A1C for patients into an estimated average glucose. This slide here gives you a table of A1C values to estimated average glucose. So if we're talking about a goal of 7, that means the patient has an average glucose of 154 milligrams per deciliter. You can keep this chart handy to help translate to patients what it means to have an A1C of 12 or what it means to have an A1C of 6. The next slide introduces our first case. This CP states she has a question about a product she read about. She read in a magazine recently that a new product that contains white kidney beans and chromium can help with blood glucose control. She would appreciate more information because she's interested in natural health care. Common presentation of patients seeking information about some product they heard about from a friend, they saw on the internet, they saw advertised in a women's magazine, etc. It is relatively common for patients with diabetes to use various supplements to try and manage their glucose. This slide shows you how the use of supplements has grown over the last 10 to 15 years in patients with diabetes. In 2001, a telephone survey was done. 78% of diabetics were taking prescribed medication for their disease, 44% were taking some kind of over-the-counter medication, and 31% were taking alternative medications or some type of supplement. In this survey, there was very low use of alternative medications for diabetes specifically. Chromium was really the only thing that showed up in 2001. Now fast forward to 2011, a survey was done in an academic medical center. Here, 55% of patients were using some type of supplement. Now, not all of them were for managing glucose. It was much more common in type 2 patients than type 1. 19% were using magnesium, 4% cinnamon, and 7% chromium. So you can see how the use has grown, and a lot of this, I think, is from popularity on the internet and the public press in touting many of these agents for managing glucose. More often than not, diabetes patients are using supplements in addition to their conventional medicines, not instead of their conventional medicines. So this could be beneficial in some cases, but it might also lead to problems such as hypoglycemia. There are over 170 different natural medications that have been used for diabetes, and there are thousands of commercially available dietary supplement products that are marketed to people with diabetes. However, only a fraction of these products have any clinical data to say that they might even possibly be effective. We're of course going to be focusing on managing glucose only and predominantly managing it in patients with type 2 diabetes. We won't focus any on supplements to prevent the development of diabetes or to treat lipid levels, because that is just way beyond what we can cover in an hour. This slide and the next one are more for you to be able to recognize why something might be in a combination supplement product. It's not to say that they're effective. The agents listed under each category, such as insulin sensitizers, have traditionally been used for this reason. Think of insulin sensitizers, they're most like metformin. They decrease insulin resistance, make the insulin that we have more effective. The hypoglycemic category, these are most like sulfonylureas. They may prompt the release of insulin from the pancreas. The next slide lists many different supplements that have been used traditionally as carbohydrate absorption inhibitors. So these are most like acarbose or precose. These are mostly sources of soluble and insoluble fiber, which slow gastric emptying and thus slow the delivery of carbohydrates to the intestines where they're absorbed. Before we begin talking about the individual supplements, I wanted to review the efficacy rating systems that I'll report for each agent discussed if available. Based on scientific evidence, Natural Standard and Natural Medicines Database each rate various supplements. Natural Standards uses an A to F system, with A being strong positive scientific evidence, and rarely ever do they give a natural medication an A, down through F, where there's strong negative scientific evidence. Rather, don't use these things. Natural Database uses an effective to possibly ineffective rating system. So an A in Natural Standard is comparable to an E in Natural Database. They're not exactly, but you can think of them as comparable to each other. So an F is comparable to a PI. And I'll report these if they're available for each supplement as we go through. Both systems don't always rate every supplement. Our first supplement to talk about is cinnamon. The order I chose to present these supplements in is pretty much by popularity and those that have the most data. We'll kind of work our way through them down to the ones that have very little data supporting their use. Cassia cinnamon, tasty spice. It's commonly promoted for lowering blood glucose. It started receiving a lot of attention when a preliminary clinical study from 2004 suggested taking 1 to 6 grams a day could lower fasting blood glucose by 18 to 29%. So how does this work? We don't really know, but we think, at least from some preliminary animal studies, we think that some of the components in cinnamon, such as cinnamonaldehyde, stimulate insulin receptors. At least in some studies, it's been shown to decrease postprandial glucose, probably by increasing GLP-1, which leads to increases in insulin release. There have been at least 10 published trials with cinnamon. It gets an insufficient evidence or C rating from Natural Database and Natural Standard. Probably the best study that's been done out there was a 2009 study of 109 people with poorly controlled type 2 diabetes. Their average A1C was 8.4%. In that study, those who received 1 gram of cinnamon, and it happened to be a Puritan's Pride formulation that's daily for 90 days, saw A1C levels fall by 0.83%. compared with standard care. And those people in standard care, theirs fell 0.37%. The difference here was 0.56%. Is what the change you saw with adding a gram of cinnamon a day. Compare that to many of our prescription products. If you look at metformin, sulfonylureas, the glitazones, you're going to see about a 1% decrease in A1C when patients are put on those. Now, it's going to change based on how high their initial A1C was, but if you take somebody like the people who are studied here who have an A1C around 8, 8.5, you're going to see a 1% decline when you start a prescription medication. Here, a gram of cinnamon a day, we saw a 0.56% decline, and that's more comparable to what you see with the DPP-4 inhibitors like sitagliptin, Januvia. There have been several meta-analyses of all the cinnamon trials. If you look at them overall, you see about a 10 milligram per deciliter decrease in fasting glucose. Over all the trials, there's no statistical effect on A1C. Now, if you look at specifically the one cinnamon trial, that's one of the more recent trials, at least there does seem to be a small impact on A1C. Now, these studies are not likely the last word on cinnamon for diabetes. It's still a hot area of interest and research. There are several other trials ongoing with cinnamon. One very important thing to talk about when we talk about using cinnamon to lower glucose is what species is used. There are 4 different species sold as cinnamon. Cinnamonium verum, which is the so-called true cinnamon. It's also labeled as Sri Lanka or Ceylon cinnamon. There's also Indonesian cinnamon, Vietnamese, and Chinese cinnamon. Chinese cinnamon, or cassia, Cinnamonium cassia, is the cinnamon that has been primarily studied. There are definitely differences in the essential oil content and other components in each type of cinnamon. Most of the time, at least when you're purchasing cinnamon as a spice, it will usually be labeled. If it's not labeled, if it just says cinnamon on the label, it's usually cassia or Chinese cinnamon because that's the least expensive of all these various forms of cinnamon. Most of the supplement products that are out there don't specify what cinnamon they used in them. It's thought that most of them are cassia because it is the least expensive. Cassia cinnamon has been studied at 1 to 6 grams a day. 1 teaspoon is approximately equal to 4.75 grams of cinnamon. It's been used for up to 4 months. Efficacy does appear to be best with 2 grams or more per day. There are some issues, potentially, with adverse effects. No significant adverse effects have been seen in the trials, but the trials pretty much have only gone up to 4 months. So we don't know what happens if someone uses relatively high doses of cinnamon for the long term. There is a concern because some cassia cinnamon products contain high levels of coumarin. Coumarin are naturally occurring plant compounds with strong anticoagulant properties. So it's the natural version of warfarin, shall we say. The problem is when we take in high concentrations of it over the long period of time. It is known to cause liver and kidney damage in high concentrations. In most cases, ingestion of cassia cinnamon won't provide a high enough amount of coumarin to cause significant toxicity. However, in those who are sensitive, such as those with liver disease and maybe kidney disease, prolonged ingestion of large amounts of cassia cinnamon might make their liver or kidney disease worse. It's impossible to know how much coumarin is in a given product. None of the U.S. supplement products have been tested that I can find. There are several published studies testing the amount of coumarin found in cinnamon spice products sold in other countries, but there are no U.S. studies. Based on those random samples taken in other countries, you would still be below the toxic dose, which is 50 milligrams a day, if you took 6 grams a day of cassia cinnamon, based on a 70 kilogram person. Several countries have come out with warnings about consuming large quantities of cassia cinnamon over the long term. The German health authorities recommend that for an adult with a body weight of 60 kilograms, that they take no more than 2 grams a day. Coumarin content is lower in the other cinnamon species, but remember I said they haven't been studied. You will find many cinnamon supplements are made with water-extracted cinnamon, which may contain less coumarin. Now the problem is people think water-extracted cinnamon contains less, but we don't really know because no one has tested them. Thus, cinnamon should be avoided in patients with liver or kidney disease, those who are pregnant, and those people taking anticoagulants. It's recommended not to use cinnamon for managing glucose in people taking anticoagulants. In those that are using antiplatelet agents such as aspirin, clopidogrel, prasugrel, etc., I suggest caution in using cinnamon and not exceeding 2 grams a day, watching for excess minor bleeding or bruising. The next agent to talk about is chromium. Chromium is an essential trace element found in mushrooms, broccoli, potatoes, beer, brewer's yeast, brown rice, and whole grains. Sales of chromium supplements have been estimated to be close to $200 million a year. Chromium has pretty poor bioavailability, so picolinate and nicotinate salts are used to improve its bioavailability. Scientists believe that insulin uses chromium as a cofactor to unlock the door to the cell membrane, thus allowing glucose to enter the cell. There have been a lot of small trials looking at the efficacy of chromium for lowering blood glucose. There are at least 15 published trials, but those 15 trials only include 193 subjects, and they all had type 2 diabetes. Chromium is rated as a PE, possibly effective, or a C rating. Overall, decreases A1C about 0.6%, so similar to cinnamon. Decreases fasting blood glucose approximately 20 milligrams per deciliter. There are negative and positive studies with chromium. It appears in the U.S. to primarily benefit those with poor nutritional status or low chromium levels. There are also several studies of using chromium in combination with 2 milligrams a day of biotin. It appears to be safe at 200 micrograms per day for up to 6 months, so at least it's been studied a little longer than cinnamon. The next slide shows you a plot from one meta-analysis that looked at the published chromium trials. If the dot appears on the 0 line, that means there's no difference between control and chromium. If the dot appears on the side that favors chromium, that says that chromium has some positive benefit. And you'll notice I didn't include everything out of this table, but what I included, and I know it's a little blurry, but the baseline A1C is over to the left. You'll see that sort of in general, and it doesn't apply to all the trials, but if you have a higher baseline A1C, you get more benefit. And you actually see that with prescription hypoglycemic agents, that the higher the A1C, the more benefit you're going to see. But if you're closer around 8 or less, you're going to see a smaller benefit. The square at the very bottom is combining all the trials, and that's where we get 0.6% overall reduction in A1C. Now on this graph it looks like it's probably closer to 0.8, but it's really 0.6 is really what the meta-analysis found. I said that chromium appears to benefit most those people who have poor nutritional status or chromium deficiency. Documented symptomatic chromium deficiencies in the U.S. are extremely rare. Where you have seen them in the past are with people who receive long-term parenteral nutrition where they were not supplemented with chromium. But we now know we have to supplement that chromium. Subtle deficiencies are a point of debate. Some people suggest that we have subtle deficiencies in the U.S. because we eat so many grain products that are highly processed. According to the National Academy of Science, adequate daily intake of chromium is 20 to 25 micrograms for adult women and 30 to 35 for men. The typical American diet contains 25 micrograms per day. So men may be at a little more risk of a subtle chromium deficiency. Another risk factor for chromium deficiency is chronic steroid use. So if a patient has both asthma or COPD and diabetes and having to take chronic steroids, they might be at risk for developing a chromium deficiency. The dosing for managing blood glucose is 100 micrograms twice a day. Zinc and calcium carbonate can decrease chromium absorption. Probably best to separate those. There's some question that in people who take these supplements chronically, is it going to cause them to have a chromium deficiency? And that has never been proven. Chromium supplements can cause some adverse effects. Most common things, hypoglycemia, rash, and lightheadedness. There is a potential for chromium toxicity. There are case reports of chromium toxicity with doses of 600 micrograms per day or greater. We don't know the exact cut point for toxicity, but most people use 600 micrograms, so don't exceed that dose. Chromium toxicity can lead to kidney failure, anemia, thrombocytopenia, hemolysis, and liver dysfunction. It's not as likely to happen with trivalent chromium salts. Chromium picolinate is Cr3+, so it's trivalent. Hexavalent chromium compounds are much more toxic when taken orally, and we'll talk about hexavalent chromium contamination on the next slide. Patients with decreased kidney function are unable to excrete excessive chromium and are at risk for toxicity. This is kind of one of those unusual things. People with chromate or leather contact allergy should avoid using oral chromium supplements. They can cause allergic reactions, rash, redness, scaling on the extremities. Another contraindication is it's kind of questionable. It's considered psychiatric disorders. It's theoretic. Theoretically, chromium picolinate preparations might affect behavioral and psychiatric conditions because picolinic acid can alter serotonin, dopamine, norepinephrine metabolism in the central nervous system, so it can alter neurotransmitters. There really haven't been any reports of worsening psychiatric conditions that I can find in people taking chromium supplements. Just one of those things, keep in the back of your mind that it's theoretical. In addition to being a kidney toxin, hexavalent chromium is considered a carcinogen. California is the only state that sets limits in drinking water for hexavalent chromium. In consumerlab.com testing of various products that contain chromium, they did find some with very high levels of hexavalent chromium. These products should be avoided. Most of these products that had high levels of hexavalent chromium were billed for weight loss. I wanted to include them here so you would know about them. Natural Factors Chromium GTF, Mega T Green Tea Supplement, and Dexatrim Max were all the ones on testing that have very high levels of hexavalent chromium. Just a couple of examples of products that passed consumerlab.com testing: GNC's chromium picolinate and Diasense chromium. Diasense is one of those products that is promoted for glucose management. Going back to our case study, what would we tell Ms. CP, who was interested in the product that contained chromium? She had read in the magazine about it helping with blood glucose control. Well, it might help lower glucose, but it primarily works in those with chromium deficiency. Chromium deficiency is not typically tested for, but it can be done with a blood test. There's questions about how accurate it is, the blood tests are, but blood can be measured for chromium content. What would we need to know about her before it would be appropriate to recommend this to her? Well, we need to know if she has kidney issues. Kidney dysfunction is common. in patients with diabetes, particularly once they've had the disease for many years. If she chose to use chromium, what dose should she stick with? Well, I think 100 micrograms BID, that's primarily what's been studied. She should avoid using greater doses, particularly greater than 600 micrograms per day, because there's no information to say that higher than 200 micrograms a day is any more efficacious. I do warn people that chromium toxicity can occur. Also, she needs to monitor her blood glucose, and I tell people to continue the current medications. Now, if chromium lowers their blood glucose, they may need medication changes. So I talk to people about being aware of the symptoms of hypoglycemia, and they need to monitor for that when they start one of these supplements, particularly if they're using one or more prescription medications to lower their glucose. The next agent to discuss is magnesium. Magnesium plays a role in glucose control and insulin homeostasis. Magnesium deficiency is not uncommon in patients with diabetes, and it can definitely worsen blood glucose and insulin resistance. So the mechanism of action of magnesium in controlling blood glucose is correcting deficiencies. It gets a possibly effective rating from natural database. There are other risk factors for low magnesium in addition to diabetes. One is long-term use of a proton pump inhibitor, especially over a year use. It's been linked to an increased risk of hypomagnesemia in several reports. PPIs are thought to inhibit active transport of magnesium in the intestines. It appears to be a class effect, and supplements can overcome the transport issue. Additional risk factors for magnesium deficiency: zinc supplements, thiazide and loop diuretics, estrogen and oral contraceptives, and tacrolimus. So if our patient with diabetes is on one of these other things or has one of these other conditions, think about magnesium deficiency if they're having difficulty controlling their blood glucose. Magnesium has been studied in at least 8 trials. Half of them have been positive and half negative. The thing is, many times these studies didn't measure people's magnesium levels beforehand or afterwards to see if they actually absorbed it. 300 to 600 milligrams of elemental magnesium per day decreases fasting blood glucose and improves insulin sensitivity. In another trial of 365 milligrams per day, they saw a 7% improvement in fasting blood glucose over 6 months. As far as dosing is concerned, recommend 300 to 600 milligrams a day. The recommended daily allowance for magnesium is 420 milligrams per day for men and 320 for women. Our average dietary intake is about 320. Again, men may be at higher risk for a deficiency. The only significant adverse effect is diarrhea. If diarrhea is an issue, they can try a different salt form. Some people have problems with magnesium oxide. Others have issues with magnesium citrate, particularly when you get in a higher dose. They can also try smaller doses. The other thing, magnesium supplements can sometimes lower blood pressure if they're being treated for hypertension. They just need to watch their blood pressure. It is recommended that patients be tested for magnesium deficiency before trying magnesium to lower their blood glucose. The only contraindication is if patients have significant kidney disease, they can't eliminate excess magnesium. So it's probably best not to supplement without someone monitoring their magnesium levels. The next agent to talk about is fenugreek. Fenugreek seeds are used as a spice in Indian cooking. Fenugreek seeds are also used to manage glucose in traditional Indian medicine. The seeds taste and smell similar to maple syrup. Preliminary research shows that type 2 diabetes patients who mix 15 grams of ground powdered fenugreek seeds with a meal have lower postprandial glucose levels compared to controls. How does fenugreek work? One thing is the seeds are 45% dietary fiber, and they also contain galactomannan. Both of those inhibit carbohydrate absorption, so because it is a fiber, it acts as a carbohydrate absorption inhibitor. But it also seems to have other effects that appear similar to DPP-4 inhibitors, that in the presence of elevated glucose values after a meal, you get stimulation of insulin release. In a 2-month double-blind study of 25 individuals with type 2 diabetes, a hydroalcoholic extract lowered fasting blood glucose and postprandial glucose, but it wasn't statistically significant. Also lowered measures of insulin resistance. So we really only have 2 published trials in humans with fenugreek, either using direct seeds or a hydroalcoholic extract. There are several other studies in animals looking at the glucose effects of it. So at this point, we really don't have any long-term studies or a significant amount of data supporting the use of fenugreek. Because the seeds of fenugreek are somewhat bitter and not terribly tasty for a lot of people, they are best taken in capsule form. If someone wants to try it, the typical dose is 10 to 15 grams per day. It can be divided up with each meal. The only adverse effects that have been reported in these small trials that have been done are GI upset and diarrhea. This is another natural product that contains coumarins. The level of coumarins appear to be fairly low in fenugreek. It's really just recommended that if patients are on antiplatelets or anticoagulants, that you monitor their use if they're used in combination. It's not labeled as a contraindication because the levels are so low in fenugreek. The contraindications are allergy to other related plants such as chickpeas, soybeans, peanuts, or green peas. Soybeans and peanuts are the only 2 I've encountered people actually having a documented allergy to, so those people should avoid using fenugreek. The other contraindication would be pregnancy. At least the extracts, higher doses of the extracts made from fenugreek have been shown to stimulate uterine contractions in animals. So that's why it's recommended to avoid higher doses higher than what you would typically use as a spice. When we're talking about using as supplements, we're using much higher doses than what we would use if we were just adding it to a dish when cooking. The last tidbit here is for patients to know that taking fenugreek supplements in capsule form, you're not going to smell that distinctive smell of this spice, but it can make people's urine smell like maple syrup. There have been case reports of infants being mistakenly thought to have maple syrup disease when their mothers were taking fenugreek as a lactation stimulant. Maple syrup disease is a metabolic disorder. The name of it's branch chain ketoaciduria, but their urine smells like maple syrup. Gymnema Silvestri is an herb native to the tropical forests of southern and central India and Sri Lanka. Its name in Hindi is gurmar, which means sugar destroyer. Traditionally, the leaves of this plant were chewed to decrease the urge to eat sweets. Extracts of Gymnema are thought to stimulate insulin secretion. A particular extract called GS4 has been studied in 2 small open-label trials. That is, there was no placebo control, so we don't know what the real effect of this is. In those 2 small trials, it reduced the requirement for concomitant diabetes medications. It's been studied in type 1 and type 2 diabetes, and decreased A1C and fasting blood glucose. Here is where we have a difference in ratings. Natural Database rates this as insufficient evidence to recommend, whereas Natural Standard gives it a B rating, which is a little higher. more comparable to a PE rating from natural database. And I'm not sure why they give it such a high rating, because really there's some suggestive evidence, but no real data to say that this is more effective than placebo, because it's never even been compared to placebo. The doses that have been used are 400 to 600 milligrams daily of an extract standardized to contain 24% of gymnemic acid. The big thing is we really don't know what the safety is, what the drug interactions are. It's not been studied long term, but you will find this in many, many combination products touted for managing diabetes. I decided to lump all of the carbohydrate absorption inhibitors together because the majority of these have very similar effects, and they're all rated possibly effective, with the exception of bean pod or white bean extract, which has no rating. These are all sources of fiber, and when fiber is consumed with other foods, it slows gastric emptying and delays carbohydrate absorption so that you get a lower peak postprandial glucose. That's where you see the benefit in patients with type 2 diabetes. All these sources of soluble and insoluble fiber have a side benefit in that most of them will also modestly decrease total cholesterol and LDL values. Just looking at one example, 15 grams 3 times a day of psyllium decreases postprandial blood glucose 14 to 20%. Glucomannan, guar gum, prickly pear cactus, and white mulberry are all other examples of fiber sources that can be used to decrease postprandial glucose. At this point, there's not a significant amount of evidence to suggest that these agents decrease A1C significantly, but they do appear to decrease postprandial glucose. Our last group of supplements to discuss are sort of the miscellaneous class. Bitter melon, Banaba, and vanadium all are rated insufficient evidence. Each has a few small trials looking at benefits. Bitter melon is a popular Southeast Asian natural product for diabetes. It seems to have an insulin-like effect, but there are no high-quality, reliable studies at this point. There have been positive and negative, poorly controlled trials with it. One important thing with bitter melon, patients with a G6PD deficiency need to avoid bitter melon. They can have a hemolytic reaction. Vanadium is another trace element like chromium that seems to have a role in insulin action. The issue with vanadium is the doses that have been studied with it are very high, significantly above what is considered the appropriate long-term intake. There is a possibility of renal toxicity with the dose that appears to be effective. It's not known if lower doses have the same benefit. One supplement I want to mention here because of issues with it is selenium. Studies have shown an increased risk of diabetes with high doses, taking more than 220 micrograms per day. So if patients are looking at using selenium supplements for some other reason, they need to stick with less than 220 micrograms per day. Nobody knows why this increases risk. Returning back to Miss CS, who asked about the combination product. So here's the label from the product she asked about. It has 200 micrograms of chromium in 2 tablets, 100 micrograms of vanadium, and 700 milligrams of Trimplex, which is a white kidney bean extract. Well, the chromium, 200 micrograms in 2 tablets, that 2 tablets a day shouldn't be a problem. The dose used in the studies, of course, was 100 micrograms twice a day. The vanadium, 100 micrograms should be okay. That's less than the 1.8 milligrams per day tolerable limit. But this dose has not been studied, and so we don't know what the efficacy of that is. The particular vanadium complex that's used in this product and used in a lot of supplements is BMOV. BMOV itself has been studied in animals and is effective in lowering glucose. Now, the issue is we don't really know what is or may be the effective dose in humans. Lastly, this product contains the white kidney bean extract, 700 milligrams, very popular right now for weight loss and for lowering glucose, but there are no studies with it. It's a source of fiber. It might be effective. The reference on this slide is a review article on trace elements and diabetes that's free. It's a very interesting article about all the information about trying to piece together the importance of trace elements and insulin homeostasis. So what would we tell CS about this particular product? I think it contains stuff that's unproven, that we don't know whether it's effective. I would stick with trying just a Chromium product if she wants to try something natural, if she didn't have any contraindications to using Chromium. Let's look at another case study. AB is a 69-year-old male, has a 5-year history of a diabetes diagnosis. Of course, he probably had diabetes for many years before that, before it was diagnosed. But current medications, glyburide, 2.5 milligrams, atorvastatin, aspirin, and allopril. A1C, 8.5, not a target, but we don't know what his goal is here, but let's assume it's to get less than 7. He's tried Chromium, Gymnema, and a pancreas elixir in the past, but does not think they help. Has a glucose monitor, but does not use it. Wants to know if cinnamon or something else natural will fix him. He happens to know his A1C because he just came from the doctor where he was thoroughly fussed at. The doctor wants him to increase his glyburide to 5 milligrams a day. With his A1C at 8.5, that's an average glucose around 200 milligrams per deciliter. He's asking about using cinnamon. So what might be the issues with him? Well, he's taking aspirin, so he may have an increased risk of bleeding because of the coumarins in the aspirin. Remember, antiplatelet agents are not necessarily a contraindication to using cinnamon. I think they're more of a caution. We would need to know if he had any liver disease or kidney disease, and we don't know that at this point. And if he doesn't know that, then we really do have to caution him about using any of these natural products. The first issue I'd really like to figure out with him is does he actually take his current medications? Actually taking his glyburide, and if he is, then maybe he does need a higher dose to get him to goal. He could add another thing in here like 2 grams or less a day of cinnamon. It would be interesting to know if we could find out how much Chromium or Gymnema he had used in the past to see if he actually used enough or for a sufficient amount of time. If we're talking about how long somebody needs to use one of these supplements, remember if you're measuring A1C, that is measuring average glucose over the life of a blood cell, which is about 2 to 3 months. So you really need to continue supplements for, I think, at least 3 months to see if you actually have an impact on their A1C, because that's really what we care about, right? So if we lower fasting glucose, that's good, but did we actually make an impact on their A1C and getting them closer to the goal we're looking at? Because if they have high glucoses at other points in the day when we're not measuring, it doesn't really matter if you get fasting down to X number. As for his question, would cinnamon or something else natural fix him? It's probably not going to be enough. Remember, with many of these supplements, we might be lowering A1C 0.5 to 0.6%. That's only going to bring him down to 8. It sounds like this guy needs some education, compliance follow-up to make sure he's actually taking his medications. What's his diet like? Probably has some other underlying issues that could be fixed that could bring down his A1C better than adding a little bit of cinnamon in here. In the next 2 slides, I just wanted to talk a little bit about combination products, because that is typically what you see promoted to people to manage their glucose, are all kinds of combos of the things we've talked about. None of them have been studied in combination, except biotin and Chromium. Those are the only 2 that I know of that have actually been studied in combination. Now this particular product here has biotin and chromium, but the biotin dose is higher than what was actually studied. The biotin dose is much higher than what's been studied. 2 milligrams is what has been studied, not 9. The chromium is higher, 400 micrograms a day. The cinnamon is 1 gram a day. Okay, that's probably not a problem, but we don't know what cinnamon they're actually using in this product. The Gymnema extract is 200 milligrams, 75% gymnemic acid. 400 to 600 milligrams is what has been studied, so this is less than what's been studied. Anaba, 48 milligrams, that falls within the range of what has been studied. What can I say about this product? The doses are a little all over the place. It's a combo product. I still think that people need to try supplements one at a time, an individual single ingredient product, see if it works. They've got to measure to see if you have efficacy. You got to measure fasting glucoses, postprandial glucoses, and A1Cs to see if it actually works, and look for adverse effects. The next slide shows you 3 other products. The 2 on the left are combo products. You can see that sometimes they add unusual things, and the doses that are in things are all over the place. The Cinnabetic 2 is a water extract of cinnamon with 250 milligrams in 2 capsules. It says that's the equivalent of 2.5 grams of cinnamon, but at least the Cinnabetic product is only cinnamon extract. This product comes from Indonesian and Ceylon cinnamon, so it's not even the cinnamons that have been studied. It likely has less coumarin, but we don't know what the efficacy would be. The next slide lists a table from Natural Medicine's comprehensive database, and they set their tables up by effectiveness down one side, safety across the top. You can see that things like psyllium and guar gum and magnesium are rated possibly effective and likely safe, but they still fall within that database's category of don't recommend using these products because they're only possibly effective. They don't rate anything for diabetes as likely effective. I take this with a grain of salt somewhat in that I think there is at least some information out there that, especially things like the carbohydrate absorption inhibitors, they might be beneficial in people modestly. Patients are going to use these things, so I think we need to know the positives and negatives about them in order to be able to appropriately guide patients. So what's the bottom line on supplements for managing glucose? None of them are going to take the place of lifestyle changes or prescription medication. I think they may have a role in supplementing prescription medications in helping get people to goal. The various fibers can lower postprandial glucose, and you get other benefits from soluble and insoluble fibers. Chromium, 100 micrograms twice a day, or magnesium, 300 to 600 milligrams a day, if someone has a deficiency, can improve their glucose. But they need to be tested for the deficiency beforehand. Cassia cinnamon, 1.5 to 3 grams a day. I think sticking with 3 grams or less is probably the place to be with cinnamon. The 500 milligram supplement, or 1/8 of a teaspoon with meals, is a place to start with the cinnamon. They can then move up to 1 gram 3 times a day, or 1/4 of a teaspoon 3 times a day. That's the max I would do because of the issues with coumarin. Until we know more about water extracted cinnamon products and their amount of coumarin, unfortunately no one's tested that yet. They may have less coumarin. You need to avoid those cassia cinnamon products in people who are anticoagulated. Use caution in people who are taking antiplatelet agents. The other things, there's just less data on them. There's really not enough information to recommend them for general use. It is important that patients monitor their blood glucose and A1C. It's also important they watch for hypoglycemia, but don't go adjusting their own medications. Whoever's managing their diabetes needs to know they're trying this supplement and that their doses may need to be decreased if it works. I hope you found this information useful.